Hello and good evening, good day to everyone. Hope you are having a lovely day. And we are back. This is 6 p.m. UK time. Therefore, it is time to start our online patient meeting. Another one. And of course, I'm your host, Caroline. It's good to be back and see all of you here as we have yet another topic to discuss. And as you can see, there is another special guest with us again. Welcome back, Dr. Fernando Sánchez. It's good to have you back. How are you feeling today?
Okay, very good. Thank you so much, and hope you are good also.
Yes, definitely. We are definitely very, very happy that you have decided to join us once again, and we'll present another topic. And just let me remind everyone that all the events brought to you has been brought to you thanks to our ambassadors and partners. And as you know, without their help, it would be very difficult to schedule so many of those events, so many topics. So thanks, as always, to their support. And today, definitely, it's an interesting topic. I know that most of you are asking those questions quite often. So it is guaranteed blastocyst program for complicated cases. And as usual, we will start with the introduction from Dr. Fernando. And let me just mention that Dr. Fernando is the gynecologist director of assisted reproduction at Ginemed clinic located in Spain. And of course, after his introduction, we will go to those most common questions. But don't forget, you will also have a chance to ask your questions. So all you need to do is just type it in the chat section so that Dr. Fernando can answer them for you and help you out a bit as well. Well, don't miss that chance, that opportunity, and go ahead and type those in. And I guess we will be able to start with the introduction. And Dr. Fernando has also prepared a presentation on our topic as well. So are you ready to begin?
Okay, so thanks so much, and good afternoon to everybody, and thanks for being here just to share a little bit our time, our knowledge, and it will be. It's also always a pleasure to be here, to be with you. And the topic today is the guaranteed programs, the advantage of the guaranteed programs, especially for complicated cases. This is a thing we learn directly from experience, because there is no way to understand these things unless you have experience on working on that. And just to make a brief presentation about the guaranteed programs, we have guaranteed programs on egg donation. And in egg donation, we have program guaranteed embryos program with 1 blastocyst, 2 blastocysts, 4 blastocysts, or even 6 blastocysts when we are trying to have to do PGS and for some genetic problems, mainly in the male, just to avoid problems. And well, this has marketing makes these beautiful names for the programs: baby for 1 blastocyst, and one more time when you have 2 blastocysts, and family when you are planning the future, 4 blastocysts, or the supreme when you are looking especially in the PGS program. Also, we have some program with guaranteed eggs in the egg donation program, because just to be sure that there is not a problem with the donor and we have enough eggs to have a pregnancy. And usually this guaranteed eggs program, usually for me is the best, because usually is the more economic. Usually when you have 8 mature eggs is the guarantee that has this program. Usually we are going to have 3 blastocysts, so is the more economic from the rest. And also we have pregnancy guarantee program with different ways. For example, we have a pregnancy guarantee program with embryo adoption, and also we have pregnancy guarantee program with egg donation, and also we have pregnancy guarantee program in IVF cycle. So there are different programs, different ways, and with this, the main advantage for me is that from a psychological point of view, is absolutely relaxed. And usually when a couple or when a woman select one of this program is very important, because usually there are persons who came after 3, 4, 5, 10 cycles, 10 5 cycles, and well, it's very difficult because everybody tells, okay, we are going to do this or we are going to do that, and this is our way of working, and for sure this kind of treatment is going to work on you and you will be pregnant in the next cycle. But after a couple of 5 cycles, it's very difficult to believe on these words. Sometimes are right, but it is very difficult to believe, and the anxiety is important. So when you have a guarantee program, you don't have to believe on the words of anyone, and you don't have to believe on the doctor. You have a contract, and with this contract, you can be sure that everything is going to work. And probably when we are working on this kind of treatments, usually we have to have the pregnancy in the first cycle. So they are very expensive for the patients, but after a couple of 5 cycles, even when they pay a lot for a guarantee program and remains pregnant in the first, they usually are very, very happy. So, but this is the information I can give you regarding to these programs and to these things. So if you is just I want just to tell you this, and so if you want, we can begin with the question and answers.
Excellent.
And I'll be here for answer any question you have.
Thank you so much for the introduction and showing us all kinds of programs available as well. And yes, it is time for those most common questions. So let's begin with the very first one. So if we use my husband's sperm, what requirements are there regarding sperm quality?
Well, if we are using a blastocyst program or a pregnancy guarantee program, we need obviously we need a sperm. This is the main thing. We don't work these programs when we have to use sperm from biopsy, testicle biopsy. So we need ejaculated sperm with minimum characteristics of normality. So usually is more than 500,000 of spermatozoa and more than 1% of normal forms, only 1% of normal forms, and more than 10% of progressive motility of the sperm. So this is a minimum quality just to be sure that we are going to have this blastocyst in a normal way.
All right, perfect. Thank you so much for answering this question. And the next one is, so how can the clinic guarantee a certain number of good quality blastocysts if my husband has a low sperm count, abnormal morphology, or very few motile sperm?
So the guarantee the number of good quality blastocysts in an egg donation program is because, okay, we began to work with the one donor, and the semen is the same, the quality of the semen. If there is low sperm count or abnormal morphology, we are going to work with this semen, and we are going to try to have the number of blastocysts that are in the program. Depending on the number of the blastocysts, we are going to and the history of the donor, because for this kind of program we are always using probe donors, that we have more information about the blastocyst rate of these donors. Depending on these numbers, we do a microinjection on the eggs on certain number of eggs, just to be sure that we are going to have this blastocyst. And sometimes we have these blastocysts, sometimes we have more, and sometimes we have less. And the problem is, well, we have less. For example, you are on 2 blastocyst program, and we only have 1 blastocyst program. So there is not a problem, because if we have 1 blastocyst, we do the transfer with this one, and we have for the same in the program from the same price is our commitment to use if you get pregnant from the same donor to have more embryos from the same donor. If you don't have a pregnancy with this donor, we usually change the donor and we do another microinjection, another ICSI, to have more embryos from another donor, until we have, unless the number of blastocysts you selected. For example, if we have 2 blastocysts selected, we have only 1, we have to do for another one, or we have 4 blastocysts, we have to follow working until we have at least the minimum number, the blastocysts you select. That's
Right.
the way.
Excellent. Thank you so much again for explaining the second question. And let's have a look at the next one. So what is sperm DNA fragmentation? Why is it a necessary test? And how can how can increased fragmentation negatively affect the cycle?
Well, there is, when we are talking about the male factor, male, there is not only number of motility or morphology. These characteristics of the sperm they are very important when we are trying to decide if we are going to work with IUI or sexual intercourse, or we are going to use IVF cycle or microinjection if we have low numbers. But when we are doing ICSI cycle or IVF cycle, or we are working in an egg donor program, for me, the most important thing is not the number, is not the motility, is not the morphology, is the quality of the sperm. And one of the ways we have to know the quality of the sperm is to know the quality of the genetic information that are inside of the sperm. You have to think that the sperm is only a vehicle to send genetic information from the testicle to the egg. And that's the reason for being so small. There's the reason for have a tail, for have the possibility of movement. And to achieve this, the sperm has to change a lot of things inside of this cell to reduce the volume and to change, for example, the proteins that are protecting the sperm, the histones in the sperm, they change to protamines that are very, very small, and they allow to concentrate this DNA, to package this DNA of the sperm in a very small amount of place. And with this sperm has a higher risk of having problems with this DNA information. And the DNA information is critical, because everything is inside of DNA. So if we have DNA fragmentation, some brokens in the chain of DNA, most of the time the egg can correct with all the mechanism that has inside the egg, because the egg is very important, it's very big, and has a lot of mechanisms to correct this DNA fragmentation, but sometimes good, sometimes not, especially when the DNA fragmentation is so high. So if we can take a look to the DNA fragmentation, if we know if the quality of the sperm is good enough to have a baby, is crucial to decide how we are going to do this microinjection, this fecundation of the egg. And this is correlated with the miscarriage rate, and is correlated also with the pregnancy rate. So it's very important.
All right, excellent. Again, thank you so much for explaining this question to us as well. Next question is, so how many donor eggs will be fertilized? Does this depend on sperm quality?
Well, we have algorithm to decide how many eggs we are going to fertilize depending on the sperm quality. Depending on the number of eggs that number of embryos that are selected in the guaranteed programs, depending on the age of the recipient, because for example, for a recipient older than 45, we are only allowed to transfer on one blastocyst, and also depending on the results that we have previously with this donor. There are in the guaranteed programs, there are always donor-proof donors, and we have information in the previous cycles about the blastocyst rate of this donor. So depending on this algorithm, we decide how many eggs we are going to fertilize to have one blastocyst.
And excellent. Thank you so much once again for this. Next question. So, what happens if the laboratory doesn't achieve the guaranteed number of blastocyst embryos after the first cycle? Will additional eggs from the same donor be fertilized in order to guarantee biological siblings?
Well, I think I answered to this question previously. If we don't have our commitment is to have this number, is you select one program, and we are going to have the things you have selected in the program. We have 4 blastocysts, we have to have 4 blastocysts. It's not possible to have 3. And depending if we have pregnancy or not, we are going to select the same donor, or we are going to change the donor. If we have a pregnancy, obviously we are going to select the same donor to have more blastocysts from the same donor, just to have brothers or sisters from the same genetic field than the pregnancy we have. If we don't have a pregnancy, the first transfer, we can change and look for another donor and select another donor to have the remaining embryos that are in the guarantee program.
Excellent. Thank you again for answering this one and confirming that for us as well. And the last question from those most common ones is, what happens if more than the guaranteed number of embryos are obtained? Will those embryos also be mined for future cycles?
Yes, of course. So this is a biological field. So the same is impossible to be sure that we are going to have the number of embryos, the exact number of embryos that are in the guaranteed program. We have less embryos, we can have less embryos, and I explained before what happens if we have less embryos. Sometimes we have more embryos. It's exactly the same. It's like a Gauss bell. So in the Gauss bell, the most frequent answer is the number of embryos we selected, but we can have less or we can have more. If we have more embryos, obviously these embryos are from the women or from the couple, and these embryos are for the couple for using whenever they want. There is obviously no charge on these embryos, and they depending on the couple for using whenever they want. With no cost at all, obviously.
Okay, thank you for clarification to this one as well. And well, it is time for our patients' questions. So there are a few questions already, but let me just remind everyone that if you would like to ask something and have some doubts, or you would simply would like to get an answer from Dr. Fernando, go ahead and type those questions in the chat section, and let me go for the first question. Okay, Dr. Fernando?
Yes, very good. I'm ready.
All right. So, would you recommend PGS test as opposed to PGD on the blastocysts? As we heard, this can be helpful since it factors out chromosomal issues that can lead to miscarriage, if we understand correctly.
Well, the PGS is not recommended in a general way, and obviously is not recommended from the point of view only of age of the mother. The PGD is completely different because we are looking for illness that we know and we have to avoid this illness. But the PGS is invasive, and we are taking a couple of cells of these blastocysts just to do the analysis. We has to vitrify these blastocysts, and we have to thaw these blastocysts later to do the transfer. And this is aggressive technique, and these aggressive techniques takes a little bit the chance of implanting of this embryo. Well, the only indication to do this is, for example, if you have repeated miscarriage. Repeated miscarriage is obviously an indication, because one of the reasons for this repeated miscarriage could be the genetic abnormality, chromosomal abnormality on the embryos. We have indication also if we have, for example, some problems with the FISH test on the male partner, or, for example, if we have some translocation or inversions in the karyotype of one of the fathers. And also, for me, it could be a good idea if we have a lot of embryos and we don't want to do too much transfers. And if there is a old mother and we have a lot of embryos and we have, for example, 10 embryos, and we want to select just to do 2 or 3 transfer on these women instead of doing 10 transfer on these women. So it's a good test, but it has some indication, not too much indication. And for me, the most important thing is to be sure that there is no indication on the age of the mother. But for example, for miscarriage could be a good idea, but not to avoid a miscarriage, only in cases when we have repeated miscarriages, several cases on that.
All right. The patient just had 2 miscarriages in the past, 1 natural, 1 from donor cycle.
Yes, 2 miscarriages, repeated miscarriage, according to the classification of the European Society of Reproductive Medicine.
Okay. Understood. Thank you. And actually, there is another follow-up, okay, from the very same patient, just a longer one. So we previously did an egg donor IVF cycle resulting in 20 mature oocytes, 5 blastocysts. After 3 transfers, we did not have success, only 16-week biochemical miscarriage. From this history, is it correct to assume we would get about 2 blastocysts from 8 mature oocytes? So does it make sense to spend more to go with a 4 blastocyst guarantee program, or is it better to spend the funds elsewhere, such as on the PGS? Partner sperm count and quality was normal, age 60.
Well, 68 of age on a male is high. We have to be sure that this sperm is normal, not only from number of morphology or motility. We have to be sure that it's normal from the DNA fragmentation, and we have to be sure that it's normal from a chromosomical point of view with the FISH technique, at least with 5 chromosomes, just to analyze. If this semen is normal on this situation, we can go with 8 mature oocytes. I think there is no need to do PGS because we are working with donors less than 30 years old. So the risk of having a problem with one of these donors if we reach the blastocyst stage, I think is very, very low, and you can be safe on this situation. Obviously, with this history of 5 blastocyst transfer, is not logical to don't have a pregnancy. Think that 1 blastocyst from an donor IVF cycle, 1 blastocyst pregnancy rate is around 68-70% on heart beating by ultrasound. After 5 blastocysts, there must be a problem for sure, or in the semen or in the endometrium, but probably is not a problem of the DNA of the donor.
All right. Thank you so much for your question as well as your advice on that as well. Okay. Thank you. And let's have a look. There is another question ready. If my partner has chromosomal problems, what his chances in donation and what are his chances in donation and surrogacy programs?
Depending on what kind of problem can have this male. If sometimes there is a translocation, depending on what kind of translocation, with what number of chromosomes are involved on these chromosomal problems. Depending if we have inversion, for example, chromosome 9 inversion pericentric is very few, very low importance. If we have more than 1/3 of this inversion is more important, but depending on what kind of problems. And obviously it's the same. We have donation or surrogacy. There is no change at all, because the question if we have a chromosomal problem in the male is the problem is with the embryo. After that, the embryo is the same if you put on one mother or on another mother. So it depending on this problem of the male.
Of course, and if you'd like to explain what you mean exactly, yes, we would be more than happy to take a look at this as well. Okay, we are waiting for some questions, so let me just remind everyone, if you would like to get some answers, just type those questions into the chat section so that Dr. Fernando can help you out. Don't miss that opportunity. Someone is typing, so we just need to wait a minute to just simply have the question. So okay, next question has shown right here. So when do you recommend immunology testing?
Well, immunologic testing we usually recommend only when we have previous problem in repeated implantation failure or in repeated miscarriage case. Usually for normal cases is not recommended, because there is no there is very unusual to have problems from immunologic point of view, apart of the normal things like controlling the vitamin D or something like this, no? But to do immunologic testing, I'm talking about especially endometrial biopsy and looking for natural killers, or looking for kill receptor or for HLA-C or HLA-G immunologic testing. So this kind of test I only recommend when we have problems. We have previous problems, especially repeated implantation failure.
Okay, understood, of course. Excellent. Thank you so much for your question as well as your assistance with this. Next question is this one. If we want to have 2 children, which program do you recommend? The 2 or 4 blastocyst guarantee?
Well, the recommendation is the 4 blastocyst guarantee, because I told you the chance of becoming pregnant with 1 blastocyst transfer on an egg donor program is around 68%. So if we have 2 blastocysts, we are lucky, we are going to have 2 babies. But if we are not lucky, we can probably have only 1. Is the most statistical point of view, the most frequent is to have only 1 baby. With 4 blastocysts, probably we are almost sure that we are going to have 2 babies, and probably we have even 1 remaining embryo in case of having bad luck or having another chance if we change. But probably the recommendation is to select the 4 blastocysts guarantee program.
Okay, excellent. Thank you once again for your question as well as your assistance with this. And we are still waiting for another okay, just saw it right here. So let me go to that. What is considered repeated implantation failure? Does it have to be a PGS tested euploid blastocyst, or do you just count the number of embryo transfers?
Well, the definition of repeated implantation failure is not everybody agree on that, but is very simple. You have to take in account, you have to have at least 4 embryos transfer before, no pregnancy, at least on 3 different transfer. At least 2 of them has to be in blastocyst stage, and with this, this is the definition we have of blastocyst, and at least no, for two different cycles. For example, if we have and also less than 40 years old, if the mother less than 40 years old. So repeated implantation failure is not possible when we are, for example, with a couple and the woman has 40 or 41 years old, because we can do a lot of transfer on a women over 40, and the problem of that is not a repeated implantation failure, it's a problem of genetic problem of these women. Also, we have to have at least 2 blastocyst transfer, because sometimes we do transfer and we saw patient who came with transfer from embryos in cells from day 2 or from day 3, and the chance of becoming pregnant with this transfer are much more lower. For this, we need at least to have 2 blastocyst transfer. And also, we need a certain number of embryos transfer. And the number we select for doing this is 4, just to be sure that from a statistical point of view, we pass the 93%. The 93% when you are going to do transfer, and you transfer more than 4 good quality embryos, usually you pass this number of 93. So this is important, and also it's important that these embryos came at least from 2 different cycles, because sometimes we have a cycle with a lot of embryos, we have cycle with a lot of eggs, and this cycle, for any reason, works very bad and don't give a pregnancy, and we repeat the cycle probably with less embryos, probably lower quality, but we have a pregnancy. So it's important that this embryo came from 2 different cycles. So if we have all this situation, we can consider that is a repeated implantation failure. And a repeated implantation failure is because we don't have any reason for telling these women, okay, you have is bad chance. A repeated implantation failure is not a question of luck. It's because we have something, and we have to study very, very hard to be sure that we found what happens in this couple.
All right, thank you so much for answering this question. And actually, there is a follow-up, okay? So let me go to this one, and we will go back to the previous question as well. So what about if you had 2 embryos transferred at the same time and the cycle was unsuccessful? Is that counted 1 or 2 in terms of implantation failure?
Well, if you have 2 embryos transfer, there are 2 embryos transfer in terms of implantation failure. So when we are looking at the part of the embryos transfer, we need 4 embryos transfer. With this, we have 2 embryos. But if we are looking at the second part, is the number of transfers, we need 3 transfer. With this, we only have 1 transfer. So with this, we have 2 embryos transfer, but only 1 transfer. We need at least 2 embryos more transfer, and we need at least 2 more transfers on the same patient. And if these embryos are, for example, on day 2, we need 2 blastocyst transfer. More. Right?
Excellent. Thank you so much for the clarification to this question. Yes, someone is typing, possibly it's our patient, but okay, yeah, okay. There is another follow-up, okay, from another patient on this. Follow-up on current question. How is repeated implantation failure considered for women over age 40?
Well, repeated implantation failure for women over 40 doesn't exist from the theoretical point of view, because when we are talking about repeated implantation failure, we are talking about problems that don't have any explication. And when we are over 40, we have explanation for this implantation failure, and the explanation for this implantation failure is the egg quality in terms of genetic number of chromosomes. So we have more aneuploidy on the embryos when we are over 40, and this is the reason for implantation failure. So the solution for this is to change. Obviously, we don't recommend to change to an egg donor program if we have a couple of 40 years old. But if we have, for example, a couple with 40 years old and we have done 4 embryos transfer and 3 transfer and blastocyst states, and we don't achieve a pregnancy, in this case, the indication is to change to egg donor program. And in this case, we can classify like implantation failure. Obviously, this is not for all, and we have to look very careful to the case in question. For example, it's not the same if you are 40 years old, but you have done PGS and we are transferring euploid embryos, or it's not the same if you are 40 years old now, but you have transfer when you are 37, 38 years old, and you don't have a pregnancy with this age, because it probably is not the same. So every case you have to look very carefully, you have to take in account everything, but mainly if you are over 40, the indication is, okay, do the transfer, but if you reach a certain number, depending on everyone, on each one, you have, and you don't get a pregnancy, it's better to change to an egg donation program.
All right, excellent. Thank you for clarification to this one as well. Okay, and follow up. Okay, and if there is one miscarriage with egg donation from 3 transfers, same donor.
So first of all, change the donor. Then you have 3 transfer with the same donor and only 1 miscarriage. It's not good result. Probably it's a problem from this cycle of the donor. Sometimes it's a problem of the donor. Sometimes it's only a problem with the cycle of the donor. But it's not logical to have only 1 miscarriage after 3 transfer on an egg donation program. So the first thing is to change the donor and to go for another donor and to do the cycle with another donor.
All right. Okay. Excellent. Again, thank you so much for that. All right. And it looks like this will be our last question, but if you have any left, you know what to do. And the question is, do you have a waiting list for the program?
No, there is no waiting list, no problem on waiting list.
Okay, thank you for the clarification. And I will ask from us in regards to this, actually, do you have like various egg donors available? Like, for example, of course, Spanish ones, but any black donors, any Asian donors also are possible to find?
Well, we have no problem with Caucasians. We have no problem with South American, with Arabs. We have no problem with Nordics. We have no problem with blacks and different kind of blacks, Afro-American, South Africans in the South, African from the South, Africans from the center, even Africans from the North. We have no problem with Arabs also. And the only problem we have is with Asian people.
Yeah. Okay.
We have there is the only one we have waiting list for Asian people, especially for Japanese. This complicated Japanese and Chinese. We have some Vietnamese and we have some Southeast Asia donor, but they are the only ones we have problems. For the rest, there is no problem. But for Asians, it's difficult because for Asian people, it's they are they don't like to be donors. It's completely different from European, for example. They don't like to be donors.
Of course. Okay, understood. Thank you for explaining this to us as well. And there is another question right here. There are some programs out there that offers 3 full IVF cycles with different donor, including all frozen embryo transfers. And if a live birth doesn't result, you receive all costs back. Is there something to be aware of considering this? It may be more cost upfront, but if you're unlucky and one has to go through 3 full IVF cycles, it would be less expensive.
Well, all these kind of programs are good because all these kind of programs are offering some kind of relax from psychological point of view. We have, for example, we don't talk about this, but we have in our clinic, we have a personalized program. And in this personalized program, we sit with the couple or we sit with the women and we decide what we want to do. For example, sometimes I have a couple, for example, the last one I have is a couple and the woman has 43 years old. And I tell, okay, the chances for you to having a baby with 43 years are very low. But if you want to try, we can try. She told me, okay, I want to try, I want to do it. And for me, it's very important to have the opportunity to do with my own eggs. And obviously, the problem is the cost. And okay, we decide we want to do 3 cycles with own eggs. And after these 3 cycles, we are going to go to an egg donor program because for me, the most important thing is this couple has to go out of the clinic with a baby. And probably we only do the 3 IVF cycles. It's difficult, but if we after that we do an egg donation program, we have more chances. But okay, we want to try with own eggs, and we organize this cycle, and we select a cost is much more lower than cycle to cycle because we decide at the beginning all the treatment. And if she, for example, if she gets pregnant with her own eggs, he has the cost back of the donation, and the costs are much more lower. All of the package you can have regarding to a program and to have a complete program of reproduction, for me, are very important. Usually are much more cheaper, are more expensive if you get pregnant on the first try, but usually are much more cheaper. And especially there is a psychological relax, tremendous psychological relax, and it's very important to have this in terms of getting a pregnancy.
Okay, excellent. Again, thank you so much for your question and your help with this. Next question is, so what is the difference in success rates between embryo adoption and double donation?
Well, the difference success rates is very low. So probably embryo adoption can have around 65% of pregnancy rate, and double donation can have around 73, 75 pregnancy rate. But there is very, very few difference in terms of success. The main difference is the thing you can choose. When you are using embryo adoption, you only have the race guarantee. So if you are Caucasian, the embryo will be Caucasian, but you can guarantee even the blood group or the height or the color of the eyes or the color of the hair. So it's very difficult because we are talking about embryos already down with previous couple, and also the information we have of this couple are much more lower than the information we have for a donor. From a donor, we have psychological tests. For a donor, we have a lot of genetic tests. We have more information about the infections, about the familiar history that we don't have. So these are the main difference. When you are in a double donation, you can select whatever you want. When you are an embryo adoption, you couldn't select nothing because there is the embryo we have. But the results are almost the same. A little bit better the double donation, but not too much.
Okay. Thank you so much once more for explaining the difference in those two as well. And are there any issues or success rates difference with frozen eggs over fresh in the no cycle?
Well, there is important difference regarding to that. When you are using fresh eggs, the chance of pregnancy is around 7 to 10 points higher than when you are using frozen eggs. And also, there is very important because when you are using frozen eggs, you have a certain number of eggs. And for example, if you selected, you have 6 eggs, the program with 6 eggs. And when you are thawing these eggs and one of them or 2 of them dies, at the end you have 4 eggs or 5 eggs. You have 1 less. If you are working with fresh eggs and you are in a 6 eggs program, and you have 6, you have 6 always. So no problem with this. And if this donor has 2 or 3 more, and there is no way of vitrifying one oocyte or 2 oocyte of a donor, so you leave this embryo, this egg, for the same recipient. So at the end, you are going to have more eggs, and at the end, you are going to have better results. The thawing is important, and not always the thawing is made in the better condition that you can have. So technically, it's a little bit complicated, and depending on the quality of the lab, you can have more problems or less problems. For example, we have an egg bank, and we used to leave eggs mainly from the Italian clinics. And depending on the clinic and depending on the lab of this clinic, we have different results with the same eggs of the same donor. So we put a donor in 2 different clinics, and the chance of getting pregnant with one clinic and the other clinic are completely different, and depending only on the way they thaw these eggs to do the egg donation cycle. So my recommendation, when possible, is better to use fresh eggs. If it's not possible or is very complicated to have fresh eggs, okay, the second chance to use frozen eggs is always a possibility. But in this case, you have to look very carefully for the clinic and the quality of the lab.
Okay, excellent. Again, thank you so much for clarification. This is definitely one of the most common questions asked. So thank you for your question as well. And someone is typing. Okay, so let's have a second and see if we do have another question. Just need to wait a bit to see, but it should be here just now. Okay, let me show you this. So if considering frozen eggs in terms of your clinic 8 mature all size program, is it better to go with a guarantee of 2 or 4 blastocysts?
Well, when we are talking about this kind of guarantee program, mainly is not a difference. The main difference is from economic point of view. My recommendation for all my patients when they ask me about okay, we have this program of guarantee program, 2 blastocysts, 4 blastocysts, the 8 mature oocytes. My recommendation for all my patients is to go directly to 8 mature oocytes. The 8 mature oocytes obviously has no guarantee in terms of blastocysts, but usually we are going to have 3 blastocysts, and sometimes even we can have 4, but the most frequent number is 3. Sometimes we have 2 only. It's possible. But in terms of economic terms, usually is the more recommendable because it's more economic. But this is the only difference. The advantage economic, the disadvantage psychological point of view, you have mature oocytes, you don't have blastocysts. So psychologically, it's better to have blastocysts, but economically, it's better the mature oocytes. But when you are in a guarantee program, you always have to pay something for the guarantee.
Okay, thank you so much. So it's like everyone needs to just make a decision based on their uh, options available, I guess, right?
So you
Okay.
have different options, and between the different options, you have to select and you have to do. And my recommendation, if I can tell you, my recommendation always is to talk with the doctor. If you want, for me, it's not a problem to organize the cycle with you. And if you want, what do you know? And you tell, okay, I want to do this, and you tell this to your doctor. I don't want to do that, and my ideas of getting pregnant is this, or my ideas is the other. I can tell you, you can go through a personalized program to do a personalized cycle for you. So it's maybe it's not only one cycle. Maybe you have to do 2 or 3 cycles if you want to select. But usually it's much more cheaper, and you are going to be much more relaxed. And obviously you are going to do whatever you want, and you are going to select the treatment you want. So talk with your doctor, think very carefully what do you want, and explain to your doctor. And for sure, your doctor is going to give you different options, and much more options that there are in the papers on the booklets that you can find in the different clinics.
Of course. Excellent. Thank you so much. And it seems that was our last question. So thank you all for joining us today for all of your questions. I just want to mention that if you would like to get some more details, of course, you can simply click on this link. There will be an option for you to ask your questions. And I'm sure Dr. Fernando and his team will be happy to help you out with all of your questions and any suggestions, of course. Right, Dr. Fernando?
Okay, very good. Thank you so much.
Excellent.
And it will be a pleasure to answer your questions. It will be a pleasure to be with you again if you want. Thank you so much.
Yes, thank you so much for your assistance today, of course, for explaining all the details. And as you can see, very helpful indeed from the patients. So thank you so much. And everyone, just let me remind you that, of course, this has been recorded. Therefore, you will definitely have a chance to rewatch it if you had any issues with the sound. I'm sorry to hear this, but remember, it has been recorded. Okay, so you will have a chance to rewatch it very very soon. And as you can see, more thank yous coming your way as well. I just want you to see all of those thank yous. Those are right.
Okay. Thank you so much.
Thank
Bye.
you so much. And let me just remind you that we will be back tonight at 8 p.m. UK time. So I hope you will be able to join us once more as we have another special guest. Jennifer Colombo will be with us. So I hope you can join. And as always, if you follow us on our Facebook page or Instagram, that way you will know when new events are coming up. And as you know, we will be back with some more of those as well. Once more, Dr. Fernando, thank you so much. Have a lovely evening. And to all of you, hope to see you soon. And of course, as well, have a lovely evening. Thank you. Bye.
Bye. Bye.